Good morning, friends, and thank you for joining us with Coding with Christine Hall. Today, I have my very good friend, Kaitlyn Brack, on the show, and we're going to discuss pediatrics. So thanks for being on the show with me today, Kaitlyn. I appreciate it.
Thank you so much for having me. I've been so excited about this conversation today.
I am glad. A couple of announcements. Today is World Hepatitis Day. It is a World Health Organization holiday. You know, I love my holidays there. And lots of great information about hepatitis. We're making new strides every day on finding a cure and for taking care of different various types of hepatitis. So you guys keep doing what you're doing. We're proud of you. Today is also National Chocolate Milk Day. So, I love my foods and I always talk about what kind of a day it is today. But I wanted to tell you, Kaitlyn, that I know you have a soccer buff in your family there.
I
And
do.
today is National Soccer Day.
Oh, I'll have
So,
to tell him.
yes. So, Kaitlyn's son, Kaysen, is an avid soccer player, goalie extraordinaire, and he's going to really enjoy this.
He's a keeper.
He absolutely is. So, pediatrics, huh? How did you
Yeah.
find yourself in pediatrics?
So I actually started in family practice, and we had somebody out for a little while, and so I was a natural fit into the pediatrics realm because it was very similar. I think if you look across primary care as a whole, so whether you have internal med, MD, DO, um, even the urgent care clinics, you're going to notice kind of similar things going on, and those are easier shifts. So I went from family practice to pediatrics because it was kind of that natural progression.
I see that. I definitely see that. And for pediatrics though, you know, I always thought that it was the same. I always gave the advice like, oh, internal medicine, family practice, pediatrics, geriatric medicine. No, it's not. There's so many different things that we consider in pediatrics. Pediatrics has different metrics that need to be monitored, and pediatrics deal with all of our vaccines, early childhood development. There's so much more than just pediatrics, right?
Well, I think what you run into a lot, especially during the preventive medicine series, um, but and I'm always intrigued, and you've heard me talk about this if I talk about E&M. But whenever you talk about like PFSH, I'm always intrigued at the social history because it changes so much, even throughout pediatrics. Because you have a newborn baby, okay, who do you live with? Who's the caretaker? Then you go to school age. Oh, what grade are you in? What favorite class? And those shifts happen very quickly. And even okay, from 1 to 2, how many words are they speaking? How much comprehension? There's a lot that goes into that.
Right. They're
And
checking on
especially,
that developmental and whether they're meeting their marks for those age, and then cognitively.
yes. And I don't know how many pediatric charges you've audited, but you'll notice a whole lot, especially with the newborn babies. You'll see a depression screening for a caretaker on those
Hmm.
newborn charges because their providers are really taking
Postpartum
the
depression.
postpartum depression a lot more seriously than what they used to, and that charge gets billed on under the baby because it's their caretaker. And
Hmm.
so we're seeing a whole lot of this. And I think I'm glad for the shift. I'm glad to see that we are recognizing and we are taking advantage of that screening because we can.
I was super excited when they released the 2021 guidelines and it allowed the parents to be an independent historian. So, true story, I was working, I was an expert witness on a case where there was a pediatric neurologist. And in his evaluation and management, he always gave credit for the parent being the independent historian. And back then, the AAP, the American Academy of Pediatrics, stated that they didn't get extra credit because that's the only way that the provider would be able to receive that information. But, that might be true for a little guy, 2 or 3-year-old. How many times have you asked your 2-year-old, like, how you feeling today? Right? What are your signs and symptoms? How long have those been going on? Anything make it better besides mommy's kisses on your boo-boos?
The
But
smiley
what
chart.
right, smile phase. Okay. But we also see that as a child gets older, they do have some interaction with that provider and they are able to, but they still require that independent historian. And I love the fact that now we can give credit in that evaluation and management that this is secondhand information that the provider has to process for those patients. So, good job, AMA.
I think it's interesting too that they made the clarification that whoever the information is from the independent historian, they don't have to physically be there, but they have to get the information firsthand from that person. So it can be phone call, but it has to be, that person.
Yeah,
So
right.
I
It
thought
has to
that was
be
interesting too.
interactive communication.
Yes. Yeah. So I
Yeah,
thought that was interesting.
I loved all those changes. I know that we're talking specifically about PEDS, but PEDS has a lot of evaluation and management. I mean, let's face it.
Yes.
That is the one of the primary procedure codes that we see in pediatrics. Actually, as you were talking about those metrics, I pulled up on my phone my new little baby. I don't know if everybody knows, but you should know I am a grandma, and my little grandson went to the doctor for his 1-month checkup, and 6 pounds, 13 ounces, 19.5. So, yeah, 2 days ago
He's
was his
so
actual
handsome.
due date. And so he's progressing exactly as we expected him to. So thrilled, making all of those developmental marks. I mean, I know I'm biased, but I might even say that I'm sure the provider was thinking genius material when she examined him. I don't know. It wasn't documented, but sometimes providers they don't always think in ink. So
Right. So I have to ask, what was his head circumference?
I wasn't there. I don't know, but I'm sure that it was in the 20s, somewhere in the 20s. If I remember right, I believe that my kids, when they were born, were in the 20s, in the early 20s somewhere.
So I don't know if you read that article from Craig about brains, but he was talking about the developmental stages of brains and the actual medical reason behind why they get the head circumference. I'll have to pull that back up, but it was a great
We would
read.
love to share that with the listeners. As you're talking
Yeah.
about Craig Larson,
Yes.
he is brilliant. But
Yeah, it
absolutely
was great.
share that with us, and we'll share it with the listeners so they can take a look at that as well. All right, so I have to ask, what are your strengths in pediatric coding? Like, what are your favorite things to see in the pediatric record as you're coding or billing for pediatrics?
So, like you said before, we get a whole lot of E&M, just because it's a lot of the times we have to be able to evaluate, and I don't see a whole lot where we do an evaluation and then bring the patient back in for a procedure. Just because we typically, like, okay, we know this needs to this needs to be done. We're going to do it. I do see a lot of impacted cerumen removals. A lot of foreign body removals.
So I got to tell you, and my sister is going to kill me, but when she was little, she put a Tic Tac up her nose. And all that I remember, and I was traumatized, was like this orange just coming down her face. Like, so foreign body removal. I get that. I totally get that, So how about vaccinations? Do you see a lot of vaccinations with peds?
I do. And something really tricky with vaccinations is, especially when you're talking about Medicaid patients and it's from that VFC program, will depend on the diagnosis order. So, like for example, I worked in clinics in Kentucky and Indiana. So in Kentucky, if we use that VFC stock, we just use that Z23. But if you go into Indiana, part of their policy for that VFC stock is that we have to use a preventative, one of those zoo diagnoses.
Uh-oh, it looks like we may have lost Kaitlyn there for a minute. But while we're waiting for her to come back, Lexi, can you run the ticker for the children's vaccines? So the American Academy of Pediatrics has an amazing children's vaccine recommendation there that you can look at. And like what Kaitlyn was saying, demographically, where we see those the use of those types of vaccinations there. So I thought that was an amazing resource for pediatric vaccinations. Um, Another thing that Kaitlyn was getting to was some of those recommended procedures that or recommended milestone markers that maybe the U.S. Preventive Task Force recommends for children. So this is a great interactive tool that you can go in and select whether it's children, adolescent, adults, geriatrics, and it's going to give you all of the recommended preventive services because we know that those are all different as we get older, not to mention they're different between men and women. Looks like we've got Kaitlyn back. It's and sometimes we have that technical difficulty. Aren't you under a flood warning right now where you're living?
Yes, we are. We're under a flood warning. There's actually parts here that are. There's homes that are partially underwater, like the schools are flooded here. So we're supposed to go back to school on the 10th, and I don't think they're going to be able to. So that's what I'm doing my best. I apologize, guys, but
No, it's okay. It's just, I know we're getting off track a little bit, but it's important to remember that, we all live in different parts of the country, and those different parts of the country, they experience climatic changes. Here in Florida, we experience hurricanes throughout the summer, and you are having flooding. There's tornadoes in the Midwest. We have fires out on the West Coast there. So we're all sometimes dealing with our own climatic changes there. And so you best be careful there, Kaitlyn. I want you to make sure that you guys are staying safe where you are. And thanks again for taking the time to be with us.
well, they've actually the fire departments here. No, they can't even get the fire trucks or any kind of saving, like to save anyone. So they have said unless you're leaving to get to safer grounds for you to not even leave because they don't know if they can get help to you. So
Wow. That's so sad. That is absolutely so sad. We've experienced that sometimes when we've had hurricanes here, where the aftermath. All right. So
We're back.
I guess staying in line with things that we don't like. What are some of the challenges of pediatrics that you have seen that maybe you can share with our listeners that might be helpful?
So this is one I would love to get Jennifer McNamara's thought process on, but one of the biggest controversies within peds is when to use modifier 22. So take for example, we have a patient who has a laceration. We need to close it. So if my provider has to use 5 stitches to close that laceration, but I also have to use 5 of my nursing staff to hold the child down, it takes me an hour and a half to put in 5 stitches, whereas it should take 5 to 10 minutes. There's that controversy on, well, it is pediatrics. It is going to be harder for you to do these procedures. It is going to take longer sometimes. But at the same time, that's not factored into peds. They're taking the procedure at its face value. Should it have taken this long? If it shouldn't, and again, I feel like an hour is excessive, I would agree with putting that 22 on. But then you have some that may argue, well, it is pediatrics. It's typical to spend an hour putting in 5 stitches because it's they're kicking and screaming and
right. But the payers are still only going to pay you for that normal 10-15 minutes of putting those sutures in. They're not going to compensate for that extra time. And we're not talking about evaluation and management. We're talking about a procedure itself. And so how do you explain when it's a prolonged procedure because of circumstances. So to me, it sounds like a modifier situation, but again, modifier 22 is a hit and miss. Sometimes the payers will, sometimes they, like you said, they'll say that it is usual and customary for the specialty that you're working in. So that's a really tough modifier, I think. I think I would love to hear more information about it. I know that we have a modifier workshop coming up soon with AAPC, the Billing Advisory Committee does. And I hope that we definitely go over modifier 22 and its challenges. But you're absolutely right. That's probably one of the biggest challenges in pediatrics.
That's why I always told my providers, okay, if you're having to use additional staff, document how much time it takes. If you're having to use any kind of extra anesthetic, or maybe even do some kind of sedation to where you can just do it. I mean, especially like, okay, my daughter is 16 months old. I can't imagine they would have to put her out because there's no way.
Okay, listen, I'm going to share a story with you too. I know my son's going to absolutely kill me. However, and Dr. Rosenstock, I think you're going to like this one. So my son had an ingrown toenail and he was about 13, 14 years old. Took him to the podiatrist to get the ingrown toenail taken out. He totally panicked. He'd never had any surgical procedures done before. And here the provider comes with this needle, which was a tiny little needle. Okay, don't let him tell you that it was really big because it wasn't, okay? But he couldn't do it. So we brought him back home. We had the pep talk with him. Here's what's going to happen. Okay, I'm ready. He went to the podiatrist the second time. Couldn't get the ingrown toenail out. By now that toenail was getting kind of funky. I'm not going to lie.
Right.
We needed to go on antibiotics. So we go back and nope. Sure enough, again, it's not possible. Now, these are bigger kids. It's not like he can call the whole staff in there to hold him down. He's 13, right. 14 years old. So long story short, we ended up admitting him to the hospital to be under general anesthesia for a 10-minute procedure to remove the ingrown toenail from him. Absolutely. Pediatrics is a whole different world, folks, and I was very happy that our insurance understood the circumstances and allowed for him to have that procedure inpatient under general anesthesia.
So I'm going to ask him. I want his feedback. So after this, I'm going to ask him. I'm like, I need you to talk me through this. How big was the needle?
Yeah.
I need to know. I have questions.
Perception is each one of our realities. So
right.
Most definitely. So
I will tell you one of my most interesting cases though. We had a patient that they had some psych things going on, but for inpatient to be inpatient at a psych facility, the patient has to go through they have to do like a full head to toe medical evaluation to make sure that there's nothing medical going on. Just because when they're inpatient psych, they're focused on the psych. They don't have medical staff there to handle
anything. Facilities are like that.
Right. Mm-hmm. Right. And so I had a provider that had to do this 3 months in a row because they didn't have any openings at the inpatient facility. And he called me, he said, Kaitlyn, I don't know how to code this. And I couldn't find anything. There's nothing that actually talked about how to code those recurrent preventives, because it was prevented from a standpoint of this was a payer requirement, right? And we weren't actually treating the condition. We were making sure that there was nothing else going on. But at the same time, patient had severe depression. So how,
sounds like a modifier situation.
Yeah. I mean, we had to do the future. Yeah. I mean, we had to do the mandated, the mandated modifier, but it was one of those, okay, because each payer only covers that preventative once per year, right? So we're if we code that as the preventive, we're going to keep getting denials on this.
Yeah.
But it was, like I said, it was just one of those things where I actually talked to a colleague about it. This is years past, and she was like, "Well, in that situation, you do code the E&M because it was for a medical purpose." So I thought that was interesting. I'd be interested to know if anybody else had ran into anything like that. But that was
Good
probably one
one.
of my most interesting cases.
So I have another question for you.
Yes.
I teach the virtual instructor-led program at AEPC, and
Yes.
I am a little biased because it's been a game changer. I have taught for decades in this industry, and I haven't seen the level of success that AEPC has been able to achieve in with the VILT program. So
Right.
shout out to the VILTs. But what about those people that are looking to get into a specialty? My students are always questioning, where do I go from here? What specialty would be best for me? How do I know that I'm going to like pediatrics? So, what advice would you have for a new coder who's looking for advice about pediatrics or getting into pediatrics?
Well, I think it's important to know that most of the time you don't get to choose your specialty. Your specialty chooses you. Because that's what happened to me. I passed my CPC exam. I got hired on by a large health system that has specialists in every realm. And so it was like, we have an opening in family practice. That's where we're sticking you. Oh, we need help in pediatrics. That's where we're sticking you. Oh, I know you've never coded general surgery, but we're going to put you there too. It's a lot of the times you don't get to choose it. But in regards to resources, I love the study guides. And I'll tell you, whenever I'm studying for an exam, the first place I go to in those study guides is the ICD-10 section, because it tells you, it's like, hey, you really need to pay attention and understand this diagnosis. And when I was actually studying for my CPED, I went to that was the first section I went to, and I had my ICD-10 book out, and I wrote down the page numbers beside each diagnosis section that where the guideline was. I wrote the guideline, which if you use AAPC's ICD-10 books, there's an eye icon beside diagnosis codes that have a direct guideline associated with them. So I was, to save time, I guess, I would write down the page number of the guideline so I wasn't looking for it.
That's a perfect idea.
It's, I mean,
I'm
especially
going to
with
recommend that
exams,
to my students from now on.
you know what I mean? Like
Yeah.
I don't, I didn't know how much time I was going to have, so I didn't want to risk it. So I that was the first thing I went to. The AAP, the AAP is a great resource. They are always giving out information. AMA, of course. Something that you guys
Absolutely.
may not know about is AAPC has newsletters that's geared toward each specialty, and it's a subscription base, but it's like 3 articles a month. You can get a CEU for completing the quiz at the end, but they actually write up on topics in real time specific to those specialties, and they have one for pediatrics. And so I read that one. I read that one often, just to see what all's going on.
Mm-hmm.
Um,
Those are all great resources. I think one of the things that I love about those resources that we have, not only at AAPC, but if you're on the list serves for some of
yes,
those payers that you participate with, they'll send you emails about what's going on. Now, don't forget, folks, no one is going to send you an unsolicited email. So you've got to get involved and you've got to request it. But those emails that come in, they do have the most up-to-date information. They are giving explanation and description of code changes or new diagnosis in your field, what's relevant to your field. I'm preparing my educations coming up on the new ICD-10 guidelines and then eventually the new CPT guidelines. And my educations are geared globally. I talk about all of those changes, but someone who is in pediatrics, they may not need to know what's going on in cardiology or what's up with the latest colonoscopies. So it's important that you are active in the academies or the associations that are for your particular specialty, and not just that you visit them, but that you request for them to send you information as well. So that's going to be a definite good resource for anybody that's deciding to go into any specialty at all. But
can you hear me? Am I back?
You're back.
Okay. Power blade. I thought something interesting, something else I was wanting to add is that there's a lot of free resources that are great. We have a lot of great free resources in our industry. I mean, look at all the chapter meeting. We have full access to any chapter meeting now. But I have to say, a lot of the ones that you pay for, the education you pay for, I feel like people get more out of it because nobody wants to waste it. Mm-hmm. So I always, invest in your education, because no one can take that away from you.
That's right. That's right. And so even if your employer isn't covering the bill for something, remember that is your education. That is your moment there to gather that information to make you the best that you possibly can be. And there's so many notes here that I'm looking through all the comments there. And if you listen to any of the other podcasts that we've had guests on, these specialties find you. It is usually the way that happens, is that you're out there looking for where you might be interested in, and suddenly that specialty jumps out and grabs you that you didn't even know you had a passion for until you get into it. And as you've said before, it clicks with you. It made sense to you. Pediatrics was a natural progression from your family practice. And so I want to encourage everybody out there to take any and every opportunity that you possibly can, right?
I seen a comment on splinters. That one's a tricky one, because that sometimes you can bill it. Some providers want to be able to bill it as a foreign body removal because you are removing it. But for most foreign body removals, they require an incision. The only foreign body removals that do not require an incision is nose. It's the nose, eye, and then external ear canal, which is what we deal with the most in pediatrics. So remember, for those, if you're billing a basic, incision and foreign body removal, it does need an incision, and it could be just making the initial opening bigger, or it can be creating a whole new opening. But there has to be some kind of, opening or expansion of that initial opening. So that is something important to.
Now, if the documentation doesn't support that there was an incision made opening the location where the foreign body is, or an additional incision there, would that just defer to an evaluation and management visit? They're just taking tweezers and pulling it out?
Yes, that gets bundled into the E&M. I usually do ask my providers, just say, hey, I noticed a foreign body removal was completed. Was there an incision for this? And that's all. I'm not trying to lead or anything, but I'm asking for clarification, because if there was an incision and they just forgot to document, that's a whole other, they're losing reimbursement there.
That's an awesome tip. Thank you so much. So I want to thank everybody for participating today and joining us on Coding with Christine Hall. I think that Lexi has a few announcements that she wants to go over before. Kaitlyn, you are amazing. I cannot thank you enough. But for our listeners, I recently got to spend the weekend with Kaitlyn in New Albany, Indiana, speaking for that AAPC chapter. And we had an absolute ball together. Networking began as an introduction, which turned into a virtual lunch, which turned into collaboration, which turned into a friendship. And now I don't know what a day in my life would look like without you in it. So thanks for being on the show today.
Thank you
truly appreciate it. Lexi, can you tell us what our listeners can look forward to?
Hi, everybody. We're having some exciting things happening this weekend. Friday, we're having Navigating the Guidelines, the Basics, from 5 p.m. Eastern Standard Time. Saturday, we're doing 2023 Evaluation and Management Guidelines at 12 p.m. Eastern Standard Time. Next week, if you're at HealthCon, check Kaitlyn and Christine out. That'll be really fun. Hope everyone has a nice day.
Thanks so much, Lexi. I appreciate it. And again, you can find links to all of these webinars. You can go straight to our website, Stirling Global Solutions, scroll down to the bottom. All of those events are listed there, except for HealthCon. But if you're at HealthCon, make sure that you do connect with Kaitlyn and myself, and you stop by and you say hi and you get to introduce yourself to us. So looking forward to seeing you there. Looking forward to seeing you Friday or Saturday. And if not, I'll see you next week after next on Friday. And we'll have a very special guest talking to us about another specialty and specialty coding. So have a wonderful rest of your week, guys. And I'll see you soon.
Thanks for watching.